You are the doctor on the ward. Sheila is a 51-year-old woman who is being treated for pneumonia after an operation on her hip. She has just finished a course of co-amoxiclav. She has no previous medical history of note and is not on any regular medications. During the ward round, she starts to have a seizure. She continues to seizure for 5 minutes before the consultant asks you to prescribe something to stop it. What should you prescribe? What's the management of seizures? You're in hospital, so you can give IV instead of buccal midazolam or rectal diazepam. You can give IV lorazepam. I guess. Let's see what's the answer. Yes, the answer is IV lorazepam. IV lorazepam is the first-line treatment in patients with early status epilepticus. The patient was seizing for at least 5 minutes, putting her in status epilepticus and requiring immediate treatment. Although benzodiazepines are a good choice in general, benzodiazepines. So all these are benzodiazepines. Guidelines state that lorazepam should be used first line if available. In a hospital setting, emergency oral medication should be avoided as patients are likely to have a cannula in place. IV phenytoin is used for seizures associated with trauma or neurosurgery. Here's some notes. Oh, nice guidelines. You need to have a look at it after this. So status epilepticus is defined as a single seizure lasting more than 5 minutes or 2 or more seizures with a 5-minute period without the person returning to normal between them. 2 or more seizures within 5 minutes without returning to normal. This is a medical emergency. The priority is the termination of seizure activity, which if prolonged, will lead to irreversible brain damage. Management, ABCs. So airway management, ABC stands for airway breathing circulation. So airway, you want to see if the airway is patent. Oxygen for the breathing and check blood glucose. That's D for dextrose and disability. Not sure why they put under ABC. ABCDE should be. Any acute situations, you do your ABCDEs, which is your airways, breathing, circulation, disability, and dextrose, and exposure. First-line drugs are benzodiazepines such as diazepam or lorazepam. In the pre-hospital setting, diazepam may be given rectally, so rectal diazepam. In hospital, IV lorazepam is generally used. This may be repeated once after 10 to 20 minutes. If ongoing or established status, it is appropriate to start a second-line agent such as phenytoin or phenobarbital infusion. If no response, refractory status within 45 minutes from onset, then the best way to achieve rapid control of seizure activity is induction of general anesthesia. So we want to have a look at NICE guidelines. Status epilepticus. Go for the general one. A is not, this doesn't look like what I'm looking for. No, this is not what I'm looking for. This is the general one. Nope. Why does it look like this? Do you not have guidelines? Epilepsy. Overview. Yes. I'll look at this flowchart. Management. It's a lot of information. So how do you diagnose? Initial screening. adult or pediatric physician with onward referral to specialist when an epileptic seizure is suspected. Diagnosis is done by specialists. I remember making a video about this, so I'm just gonna go ahead and change it. Earphones so you don't get double sound here. Okay, here's my earphones. It's under YouTube. Epilepsy. Yeah.
Hello everyone, so today we'll be looking at epilepsy according to NICE guidelines. These are the full guidelines, so if you want the full guidelines, here's a link to it. My other references include Oxford Handbook of Clinical Medicine, the 10th edition, patient.info, and also gov.uk for epilepsy and driving. So before we get started, let's get familiarized with the terms used in this presentation. So epilepsy, what does it mean? At least 2 unprovoked seizures more than 24 hours apart, or 1 unprovoked seizure and a chance of another seizure of at least 60% in the next 10 years. You might think, how do we know the probability of another seizure in the next 10 years? Usually, I think, if I'm not mistaken, it can be calculated using an EEG. So after usually EEG will only be done after 2 seizures, but in some cases the specialist might decide this person needs an EEG after their first seizure. So after the first seizure they do EEG, and then in the EEG you see something known as unequivocal epileptiform activity, and then this has a high chance of another seizure. So that's where this comes from, I guess. And then also epilepsy is a diagnosis of an epilepsy syndrome. So syndrome, is a set of symptoms. We'll see what epilepsy syndrome means in the next page. So next term is epileptic seizure. So seizure, it can be epileptic or non-epileptic. Epileptic means that it's because of excessive or synchronous electrical activity in the brain. And then specialist, basically it's either a pediatrician or a medical practitioner who has a training or some experience in epilepsy. So significant amount of their workload related to epilepsy. And then one level up from the specialist is a tertiary epilepsy specialist. It's an adult neurologist who devotes a majority of their working time to epilepsy and works in a multidisciplinary tertiary referral center with lots of facilities and subject to peer review. And then epilepsy syndrome, we mentioned just now. So what does it mean? It's a distinctive disorder identifiable on the basis of typical age of onset, seizure type, specific EEG characteristic, and often other features. So a set of different things you call it epilepsy syndrome. And then seizure type, we actually learned this before. It's absent seizure, focus seizure, generalized tonic-clonic seizure, myotonic seizure, tonic or atonic seizure. So these are seizure type. Okay, so a quick recap on how we classify seizures. You have focus seizures and generalized seizures. Focus seizures, you can have impairment of consciousness or without impairment of consciousness. Whereas generalized seizures, you have absent seizures, tonic-clonic seizures, myoclonic seizures, atonic seizures, and infantile spasms. And then also, focus seizures can evolve into generalized seizures. You call it focus seizures evolving to bilateral convulsive seizure, or the older name is more simple, so secondary generalized seizure. And these are some of the symptoms that you can experience based on the lobe of the brain that's affected. So temporal lobe, is a memory, right? So you can have things like deja vu, jamais vu, everything is strangely familiar, unfamiliar. Or you can have emotional disturbance. We know memory is strongly tied with emotion, and also the olfactory area is around here, so you have hallucinations of these modalities. Frontal lobe, we know the precentral gyrus is in the frontal lobe. So motor disturbances, you can have posturing, pedaling of the legs, motor arrest, Jacksonian march, thoughts, palsy, dysphasia. And parietal lobe, you have sensory disturbance, tingling, numbness. Occipital lobe for visual disturbances, you can see spots, lines, or flashes. And quick recap on how we take a history in loss of consciousness. So epilepsy basically uses a normal loss of consciousness history taking. So what happened? You have to think what happened before, what happened during, and what happened after. So in epilepsy, before you want to ask, what were you doing when you had a fit? You have bright lights that trigger. Maybe you're at the disco, you saw some bright lights and suddenly you have a fit. So probably it's the trigger. Then some people might feel an aura before they have their seizure. These auras can be any of these symptoms. You can have maybe this person sees spots or lines or flashes before you have the seizures, and then during you ask about motor symptoms. So are they stiff or flaccid? And then were they jerking? Stiff or flaccid? Flaccid, maybe you have atonic seizure, then the rest you have stiff. And then flaccid also you might think of syncope as well. And then how long was the seizure? Usually you have to ask this collateral history for this one because the person is unconscious. So ask an observer, anybody with them. And then after they realize any tongue biting or incontinence after that. And sometimes you can have post-ictal, especially for generalized seizures, you can have post-ictal confusion and drowsiness. So how long does it take to recover back to normal? So here's a case of Ali, 17 years old. You took a history. He came in and he said he has a seizure. So you take a history from him. What happened before? So he was at the disco when he was having a seizure. He was drinking a lot. Were there any drugs? You asked, but he denied. But you can't be sure, so you have to check his urine and all. No aura. He didn't complain any aura. It just come on suddenly. Actually, alcohol suppresses brain activity. So don't quote me on this, but alcohol should not cause seizure. Withdrawal of alcohol will cause seizure. Might cause seizure. Okay. During. So he went with his girlfriend, and the girlfriend witnessed the whole thing. His whole body was stiff, and then his eyes rolled up, and he was joking. Sawan lasted for 3 minutes, and then after that, he realized that he wet himself, and he was drowsy for about 20 minutes before going back to normal. So some of the relevant after taking history, you take physical examination. Some of the relevant physical examinations that you should take according to NICE: cardiovascular examination, taking of syncope, neurological examination, mental state examination, and developmental assessment. What's your role as a GP? So you have to think of differentials. Is this a syncope? Think of other things. These are some of the differentials you can think of. You have to ask the question: is this an epileptic seizure? So we saw what an epileptic seizure is at the beginning of this video. It's a seizure caused by excessive or excessively synchronous activity, electrical activity in the brain. If yes, it's not up to you to decide whether it's epilepsy or not. NICE actually emphasizes this quite a lot. It's not up to you have to refer to the specialist. It's not up to the general practitioner to diagnose epilepsy. So you only think whether it's an epileptic seizure or not. If you think it's an epileptic seizure, you need to urgently, within 2 weeks, refer to the specialist in epilepsy. And also, you have to educate the patient importance of reporting further attacks, and also teach them first aid. We'll touch on first aid later on. So what if another seizure happens? What are you supposed to do? Investigations as a GP, some investigations I can order are ECG, probably thinking of some sort of heart rhythm disorder that might cause a syncope, or you look at bloods, look at electrolytes, glucose, calcium, which might cause the seizure. EEG and neuroimaging usually ordered by specialists, but as a GP also you can order, probably the facility is not there, in an ED, in the emergency department, they might order a CT if a stroke, if a TIA or stroke is if in acute situations, if they suspect TIA or stroke. EEG usually ordered by specialists, neuroimaging also usually ordered by specialists. MRI is preferred, obviously because MRI has more soft tissue details compared to CT, but CT is much faster, much cheaper. CT might be done if MRI is not available, or MRI is contraindicated, maybe you have a metal implant, or sedation is required for children. So usually children will move around a lot, and then you can't make them sit still, right? And then you have to sedate them, and then you expose them to further risk of sedation. So you might want to consider a CT instead of MRI in these cases. A NICE quality statement. So NICE emphasizes that the specialist is the one who diagnoses and manages epilepsy. And the rationale behind this is because in the GP setting, lots of misdiagnosis occurs, and as much as 5 to 30% of epilepsy is misdiagnosed. And I think I got the slides order wrong. So this is the reason why you want to refer to a specialist. Oh yeah, correct. So this is the reason why GP cannot handle epilepsy, why so many misdiagnoses. So in the management of epilepsy, you want to give anti-epileptic drugs, and the principle is that other than you have to discuss with the patient and the patient family about side effects, which one is a shared decision making. Other than the principle of shared decision making, another principle is you want to treat the epilepsy on the basis of the epilepsy syndrome. And if it's not clear representation, you want to treat it based on the seizure type. So not all epilepsy you give the same drug. Some drugs might exacerbate certain epilepsies. So we'll see why specialist is required, because look at this epilepsy syndrome. There's so many syndromes with all these weird names. Maybe some of them you heard before, but most of them there's so many of epilepsy syndrome, and there's so many anti-epileptic drugs to choose from. So it's very easy for somebody who's not specialized in epilepsy to make a mistake in diagnosing any of these syndromes. So role as a GP is to refer to specialists if you think it's an epileptic seizure, according to NICE. And then this is seizure type. So absence seizure, give ethosuximide, and then the rest. I'm not going to go into each of this. You can look at it yourself in your own time. But what we do need to know is that sodium valproate is teratogenic. So all women with on AD, not just sodium valproate, should be offered 5 mg per day of folic acid before any possibility of pregnancy. And these are quite emphasized in NICE guidelines as well. Do not offer sodium valproate to women or girls of childbearing potential, unless other options are ineffective and pregnancy prevention program is in place. Pregnancy prevention program basically is contraception. Contraception is quite complicated in epilepsy as well, because a lot of the anti-epileptic drugs are CYP450 enzyme inducers, and then any progesterone containing contraceptive pills and all that will be affected by this. And then another thing is estrogen. Both estrogen and progesterone have problems. So progesterone once won't work very well, and estrogen once you will actually decrease the levels of lamotrigine, if I'm not mistaken. Let me see. Where's my speaker notes? Lamotrigine, yes. So lamotrigine levels are affected by estrogen. Estrogen decreases lamotrigine levels, so it's quite complicated. So, and when do we need to refer to a tertiary specialist? We talk about the tertiary specialist is one step above the specialist when there's diagnostic doubt, or when there's treatment failure, or when it's complicated. And I don't know what's with the obsession with the number 2. So epilepsy is not controlled within 2 years, or management unsuccessful after 2 drugs, or child under age of 2 is considered complicated, or you have other problems here. And how do we stop the AEDs? The principle is that you have to be seizure free for at least 2 years. Then you have to discuss with the patient about the risk of if you stop this drug, you might get a seizure. And then if they're on more than one drug, stop one drug at a time, and stop each drug slowly over at least 2 to 3 months. For benzodiazepines and barbiturates, you need longer, 6 months. So you see Ali again. It's your off day. You see Ali at the local shopping mall. He saw you too, and he waved at you when he suddenly dropped to the ground and started fainting. What do you do? So first aid for seizures. So check for danger. Any dangerous objects around him. Maybe a trolley is there. You move the trolley away from him. Maybe sharp objects, you move it away. Any like big necklaces that might choke him, take it out. Glasses, take it out. Do not restrain. If you have pillow, put it under the table. Probably in the shopping mall. No, you don't have pillow. Do not restrain him. Wait and time. So you look at the time. If it's not within 5 minutes, you put him, check away, put in recovery position. If still fitting more than 5 minutes, this is compulsive status epilepticus. And how do you manage compulsive status epilepticus in a community setting? Any of buccal midazolam 10 mg, or rectal diazepam 10 to 20 mg, or IV lorazepam. But usually in the community you wouldn't have IV access and resusc facilities. So usually buccal midazolam, buccal in the mouth midazolam, rectal diazepam. One of these. And then after you give, you wait another 5 minutes. And then if they still fitting after 5 minutes of giving this, call an ambulance. Well, some people, it might be the first time that they're having compulsive status epilepticus and they don't have buccal and rectal diazepam with them. So what do you do? So after the 5 minutes, you know this compulsive status epilepticus, just straight away call the ambulance because you don't have this, this is their first time presenting with a prolonged seizure, more than 5 minutes. So they don't have these drugs with them. Right. And then ambulance bring them to hospital. What the doctors do in the hospital: ABCD, airway, secure the airway, breathing, assess respiratory function, recognize high concentration, give a high concentration oxygen, circulation, assess the cardiac function, and get IV assess large ball cannula in the large veins, and then check their blood glucose. And in the hospital, they will give IV lorazepam because they have IV access. But if IV access not available, yeah, if lorazepam is not available, you give diazepam. If no IV access, passmedicine. So this maximum you can have 2 doses, including the pre-hospital treatment. So pre-hospital treatment is the one here. So if you haven't given anything because he doesn't have the drug, then you can give this 2 doses of this. You can try 2 times. But if you already give 1 time in the community, then you can only give 1 more time in the hospital. So max 2 doses, including pre-hospital treatment. Then second line, see if seizures continue, IV phenobarbital or IV phenytoin. There's actually a very detailed table or nice guidelines about this. If you're interested, you can go and look at it. And then if they have a very, very long seizure up to 30 to 90 minutes, it's known as a refractory status epilepticus, and this is usually managed in ICU under general anesthesia. And lastly, epilepsy and driving. If you have a seizure that causes a loss of consciousness while awake, you need to inform DVRA and your license will be taken away. So there are 2 types of licenses. You have the personal one and your heavy vehicle one. Like always, the personal one is more lenient than the heavy vehicle one. Personal one, if it's a one-off seizure, it can be applied after 6 months being seizure-free. If it's a seizure due to changing of the dose of medication or changing of medication, you can reapply after 6 months being seizure-free. If more than 1 seizure, you can reapply after 1 year being seizure-free. Whereas for a heavy vehicle, it's quite strict. So if it's a one-off seizure, you can only reapply after 5 years of being seizure-free and not needing any medication. So this one can be seizure-free and on medications, you can reapply. But this one you have to not need medications and be seizure-free. And then if you have more than 1 seizure, it's 10 years. It's just unrealistic. I mean, who would report to DVRA if it's like this, but it's for the safety of the public. And that's all for my presentation.
There you have it. IV lorazepam is first line. If not available, IV diazepam. That's in hospital. And if IV access is not available, then baclomidazolam. Was it baclomidazolam? Oops. Recently closed.
Like big, please. And then after you give
This is in the community. So in the community, either baclomidazolam or rectal diazepam. Then in hospital, after you do your ABCDs, first line is IV lorazepam, second line is IV diazepam, and then third line is baclomidazolam. I did this after reading the NICE guidelines last year. So good thing I did this because I already totally forgot about it. I mean, forgot quite substantial part of it. Okay. Next question. An 18-year-old man is bitten by a frantic dog whilst taking a gap year in Ecuador. He is worried about rabies and phones for advice. He was not immunized against prior to traveling to Ecuador. What is the most appropriate advice after thorough cleansing of the wound? Thorough cleansing of the wound, you can give vaccination straight away, if I'm not mistaken. Give human rabies immunoglobulin plus full course of vaccination. Give human rabies immunoglobulin plus oral penicillin for the next 2 weeks. Advise low risk but take oral co-amoxiclav for the dog bite. Give human rabies immunoglobulin. Give full course of vaccination. If I'm not mistaken, it's to give full course of vaccination. I'm not sure you need antibiotics for the wound or not, but there's no vaccination plus antibiotics. I don't think immunoglobulins are needed at this point. If I remember correctly, rabies you can treat immediately with vaccination after the bite. So let's try. Is there any other? Okay, the advice low risk oral comoxiclav There must be a reason the question stem says Ecuador, which is not a very developed country. Maybe rabies is endemic in that area, so not gonna advise low risk. Give human rabies immunoglobulin, which is a bit too much, I think. The other two also has rabies immunoglobulin. So my final answer is E. Let's see if it's correct. No. So you need to give the rabies immunoglobulin plus full course of vaccination. Wow, my answer is not that popular, huh? Rabies, following possible exposure, give immunoglobulin plus vaccination. Okay. What was the other? Oh, the other one was tetanus. Tetanus was the one that you don't need to give immunoglobulin, so you can straight away start vaccination. Is it? Tetanus. Don't know. Let's see what the other people are saying. Bad question. It doesn't specify whether the man or dog is on their gap year. What? Explore the reasons for the frantic behavior of the dog. I think they're just talking nonsense now. So we only give IVIG. What about all the other bugs that dogs have in their mouths? Shouldn't we give antibiotics as well? Rabies is bad. Other infections bad, but not rabies. Huh? Rabies is fatal. One symptom you may as well be dead. Okay, I learned something today. Rabies, very dangerous, so you gotta treat as aggressively as possible. Rabies is a viral disease that causes an acute encephalitis. The rabies virus is classed as a RNA rhabdovirus, specifically a lysavirus, and has a bullet-shaped capsid. The vast majority of cases are caused by dog bites, but it may also be transmitted by bat, raccoon, and skunk bites. Following a bite, the virus travels up the nerve axons towards the central nervous system in a retrograde fashion. Rabies is estimated to kill around 25,000 to 50,000 people across the world each year. The vast majority of disease burden falls on people in poor rural areas of Africa and Asia. Children are particularly at risk. Features: prodrome of headache, fever, and agitation, hydrophobia, water-provoking muscle spasms, hypersalivation, Negri bodies, cytoplasmic inclusion bodies found in infected neurons. There is now considered to be no risk of developing rabies following animal bite in the UK and the majority of developed countries. Following an animal bite in at-risk countries, the wound shall be washed. If an individual is already immunized, then 2 further doses of vaccine should be given. Okay. If it's already immunized, then you give 2 further doses of vaccination. If not previously immunized, then you need the immunoglobulin. So human rabies immunoglobulins, HRIG, should be given along with a full course of vaccination. If possible, the dose should be administered locally around the wound. What? What dose? Vaccination dose? Oh. So you inject near the wound for the vaccination, huh? If untreated, the disease is nearly always fatal. Here's a video on rabies. Let's have a look.
Rabies is a very rare disease in the US, which is fortunate because it's extremely deadly. In fact, once you show symptoms, it's essentially 100% fatal, with the exception of only a few case studies. And rabies is not endemic in humans. It's transmitted to humans from animals, either dogs, hence the term rabid dog, or bats, or some other animal. And actually, there are a lot of animals that can carry rabies, which should strike you as strange, because usually viruses are optimized for one particular species. Now, the reason rabies is different is that it's actually caused by a number of different viruses, not just one. But all of these viruses are in the lysavirus genus within the rhabdovirus family. Now, the way infection works is that when a dog or a bat or some other animal bites you, the rabies virus infects your muscle cells, replicates there, and then gets into sensory and motor nerves and travels by retrograde axonal transport to the spinal cord, where it jumps across synapses into the next neurons and then travels up to the brain. Now, easily said, but this can take a long time, and the incubation period can last from a week to as long as a year. And it depends in part on where you get bitten. The closer the bite is to the brain, like a bite on the face compared to the foot, the quicker it can get to the CNS, because axonal transport takes time. Now, this long incubation period is important to note because it's a time when we can intervene with vaccination, which we'll talk about soon, whereas once symptoms start, it's too late, the patient will die. Now, once in the brain, the virus infects neurons. And if you were to look at some infected brain tissue under a microscope, you might see Negri bodies, which are eosinophilic aggregates of viral proteins in the cell that clump together. So that's how it gets to the brain. But actually, once the virus starts replicating in the brain, it can now spread outwards again, along nerves to the eyes, salivary glands, skin, and so on. And this most likely happens in animals as well, which would explain why dogs and bats can infect you by biting you because the virus came back out of the brain into salivary glands. So how does rabies look clinically? Well, first you have a prodromal phase with flu-like symptoms, nausea, vomiting, and then only after that do you get encephalitis with fever, agitation, hydrophobia, meaning fear of water, pharyngeal spasms, coma, flaccid paralysis, seizures, respiratory and vascular collapse, a lot of things clearly. The upshot is nearly everybody dies and quickly too. And that's why I told you about negribodies, because you might conceivably have someone come in with all these symptoms and die before you can make a diagnosis and then do a brain biopsy post-mortem to see what happened. But either way, even if you had diagnosed the person while alive, there's no meaningful treatment to speak of.
No meaningful treatment, so you gotta treat it very aggressively. If they're not vaccinated, definitely give immunoglobulins. Okay, next question. You are asked to organize a tutorial on child protection for medical students attached to the surgery. When discussing patterns of behavior which may point towards child abuse, which one of the following is the least likely to be relevant? Frequent attendances to see the GP? Probably not. Since you are going to the GP frequently, why would you go to the GP frequently if you are abusing your child? You might just get found out. Late presentation following injury? Yes, definitely. History of child abuse least likely to be relevant, so that should be the answer. Late presentation following injury? Yeah, you probably wait until you think it can heal on its own and then wait until this is not getting better on its own, then you bring to the hospital. That's late presentation. History of child abuse in the family? Any history of previous things happening? There's a higher chance of it happening again because it's the same person doing it. Torn frenulum? What's a frenulum? It's part of the mouth, isn't it? The top of the mouth, between the nose and the mouth, I think. Let's check. Frenulum is a small ridge or fold of skin that helps to anchor a semi-mobile body part. Frenulum, and found on the penis, under the penis, under the tongue, inside the lips, as part of the female genitalia. I see. So any frenulum. So is that what you mean? So yeah, this is the frenulum. This is another frenulum. Under your penis, you also have a frenulum. So torn frenulum, maybe torn frenulum. I'm not sure how you can tear the frenulum in the mouth, but torn penile frenulum might indicate a sexual abuse. Poor weight gain, definitely you are not feeding the child properly. So only one not likely relevant is frequent attendances to the GP. Yep. Frequent attendances to the A&E department rather than GP may point towards child abuse. Oh, is it? As parents presume, they will see a different doctor each time. If you go to the GP, it's the same person each time, and then they'll suspect something. But if you go to the A&E, each time might be a different doctor. So, yeah, making it less likely suspicions will be aroused. Child abuse presentation. Children may disclose abuse themselves. Other factors which point towards child abuse include story inconsistent with injuries, repeated attendances to A&E departments, late presentation, child with a frightened, withdrawn appearance, frozen watchfulness. Possible physical presentations of child abuse include bruising, fractures, particularly metaphyseal. What's the metaphyseal? I think it's the part of the bone, near the end of the bones, the growth plates. Yeah, so this is the metaphyseal fractures. Particular metaphyseal posterior rib fractures, so you hit from the back. Multiple fractures at different stages of healing. There's a telltale sign. Torn frenulum, for example, from forcing a bottle into a child's mouth. I see, so that's how you have a torn frenulum. So they're talking about the tongue and mouth frenulum. Burns or scalds. Failure to thrive. It's same as very bad weight loss. I mean, not very good growth. Poor weight gain. Yeah. Sexually transmitted infections. So these are sexual abuse. Chlamydia, gonorrhea, trichomonas. Okay, next question. A 55-year-old female presents with symptoms of fatigue. Blood tests reveal sodium is normal. Normal is 135 to 145. Potassium is normal. Normal is 3.5 to 5. Urea is normal. It's less than 7. Creatinine is normal, I think. Hemoglobin is slightly low, even for a female. 10 is on the lower end. MCV is mean corpuscle volume, which is the size of the red blood cells. Normal is 80 to 100, if I'm not mistaken, and then 110 is high. So you're having macrocytic anemia. So what's causing this macrocytic anemia? Platelets are normal. Normal is 150 to 400. White blood cells are normal. 4 to 11 is the normal value. A blood film shows hypersegmented neutrophils. Oh, this is actually something key. This is a keyword to some diagnosis, which I don't really remember. So something is causing it. Is it some sort of lymphoma? Some sort of cancer of the blood? Which investigations will be most likely to confirm the diagnosis? So you already done a blood film. You have macrocytic anemia. How are you going to confirm the diagnosis? Iron studies definitely not confirm the diagnosis. It's less specific than a peripheral blood film where you look at the cells under microscope. Iron studies can mean a lot of things. Low iron can mean a lot of things. Hematinics, including B12 and folate, it's one of the causes. B12 or folate deficiency is one of the causes of macrocytic anemia. However, you already see hypersegmented neutrophils, which already point you to something more specific. So you want to confirm the diagnosis, you gotta be even more specific. APTD is any blood clotting disorders. It's not specific at all. Bone marrow biopsy is very invasive, but definitely you'll be more specific than looking at the blood under microscope. HB electrophoresis. What are we looking for in HB electrophoresis? Thalassemia? I'm not sure what we can find out. I'm gonna go for bone marrow biopsies. Either one of these two, I think. Oh, answer is hematinics. It's food. It's not even close. So, why? Let's find out. It's okay, we're learning. This patient has a macrocytic anemia. Yes, hypersegmented neutrophils on the blood film indicate a megaloblastic anemia. Let's see how hypersegmented neutrophils look like. Hypersegmented neutrophils. So these are hypersegmented. Looks like this. I see lots of blobs here. Megaloblastic anemia. The hematinics blood test that detects levels of B12 and folate, a deficiency of which produces megaloblastic anemia. Therefore, this is the best test to confirm the findings on blood film. So I had a wrong understanding of what hypersegmented neutrophils mean. So it just means megaloblastic anemia. So they're waiting and waiting for this B12 and folate to try and mature, but they can't. So the nucleus kind of already replicate a lot. Iron studies are unnecessary. A raised MCV excludes iron deficiency, that's right. Platelet count is normal and there is no indication in history of blood tests to assess the patient's APTT. Bone marrow biopsy is not indicated. White cell count and platelet counts are normal. I see. I was over suspicious. HB electrophoresis is used to detect hemoglobinopathies such as sickle cell or thalassemia. These do not cause macrocytic anemia. Thalassemia is microcytic, I think. Blood films, typical pictures. So here are your keywords here. Hyposplenism, for example, post-splenectomy. Celiac disease occurs in around 30% of celiac patients. You will see target cells, whole jolly bodies, pamphymer bodies, siderotic granules, acanthocytes. And deficiency in anemia, you also see target cells, you see pencil poikilocytes. If combined with B12 or folate deficiency, a dimorphic film occurs with mixed microcytic and macrocytic cells. Not sure what that means. Myelofibrosis, teardrop poikilocytes, intravascular hemolysis, schistocytes, megaloblastic anemia, hypersegmented neutrophils. So let's just learn a bit more about megaloblastic anemia and hypersegmented neutrophils, since this is what this question is about. So this is how hypersegmented neutrophils look like. Science Direct, huh? But Wikipedia is better concise, although it's not 100% reliable, but it's a good overview. Neutrophil hypersegmentation can be defined as the presence of neutrophils whose nuclei have 6 or more lobes, or the presence of more than 3% of neutrophils with at least 5 nuclear lobes. This is a clinical laboratory finding. It is visualized by drawing blood from the patient and viewing the blood smeared on a slide under a microscope. Normal neutrophils are uniform in size, with an apparent diameter of about 13 micrometers in a film. When stained, neutrophils have a segmented nucleus and pink or orange cytoplasm under light microscope. The majority of neutrophils have 3 nuclear segments, or lobes, connected by tapering chromatin strands. A small percentage have 4 lobes, and occasionally 5 lobes may be seen. Up to 8% of circulating neutrophils are unsegmented or band forms. The presence of hypersegmented neutrophils is an important diagnostic feature of megaloblastic anemias. Hypersegmentation can also be seen in many other conditions, but with relatively less diagnostic significance. Hypersegmentation can sometimes be difficult to assert, since just open a link here so I don't forget. To assert nice inter-observer variation is high, and segmentation may vary with race. A 1996 study performed in the United States found that blacks have greater neutrophil segmentation than whites. Association with other diseases, megaloblastic anemia. Neutrophil hypersegmentation is one of the earliest, most sensitive and specific signs of megaloblastic anemia, mainly caused by hypovitaminosis of vitamin 12 and folic acid. So these are the main causes. Nuclear hypersegmentation of DNA in neutrophils strongly suggests megaloblastosis when associated with macrovalocytosis. If megaloblastosis is suspected, a formal lobe count or neutrophil above 3.5% can be obtained. Hypersegmentation persists for an average of 14 days after institution of specific therapy. Other causes, you got hereditary hypersegmentation, acute megaloblastic anemia secondary to nitrous oxide anesthesia, myelodysplastic syndrome, myeloproliferative disorders, but it's more rare, huh? And probably because myeloproliferative disorders like lymphoma, leukemia, they are you probably will see some changes in the white blood cells and platelets, but in this case the white blood cells and platelets are totally normal. White blood cells normal, platelets normal. So you want to think of the more common causes. Most common cause of megaloblastic anemia is B12 and folic acid deficiency, hypovitaminosis. Chronic infections can cause it as well. Chemotherapeutic and cytotoxic drugs like 5-fluorouracil, hydroxyurea, hydroxycarbamide, methotrexate, following granulocyte colony stimulating factor administration, steroid therapy for immune thrombocytopenic purpura, iron deficiency. Iron deficiency anemia. Are you sure this causes hypersegmentation? This causes microcytic anemia. Why is this here? Strange old Wikipedia. Maybe very, very rare. It sounds like the complete opposite end of the spectrum though. Okay, so megaloblastic anemia. Let's learn a bit about this. Megaloblastic anemia is a type of macrocytic anemia that results from inhibition of DNA synthesis, yes, during red blood cell production. Results from inhibition of DNA synthesis since the B12 or folate is required for your DNA synthesis. When DNA synthesis is impaired, the cell cycle cannot progress from the G2 growth stage to the mitosis stage, so they cannot replicate, you see. This leads to the continuing cell growth without division, which presents as macrocytosis. Megaloblastic anemia has a rather slow onset, especially when compared to that of other anemias. The defect in red cell DNA synthesis is most often due to hypovitaminosis, specifically vitamin B12 deficiency or folate deficiency. Loss of micronutrients may also be a cause. Megaloblastic anemia, not due to hypovitaminosis, may be caused by antimetabolites that poison DNA production directly, such as some chemotherapeutic or antimicrobial agents, for example, azathioprine, trimethoprim. The pathological state of megaloblastosis is characterized by many large, immature, and dysfunctional red blood cells, or megaloblasts, in the bone marrow, and also by hypersegmented neutrophils, defined as the presence of neutrophils with 6 or more lobes, or the presence of more than 3% of neutrophils with at least 5 lobes. These hypersegmented neutrophils can be detected in the peripheral blood using diagnostic smear of a blood sample. Yeah, so megaloblastic anemia. This means that it's because of the DNA synthesis is impaired. So you're stuck in the G2 phase without going into mitosis. So you just grow and grow and grow. And the nucleus becomes hypersegmented. Hypersegmentation means more than 6 lobes, or more than 3% of the blood has 5 or more lobes. Okay. Goody, we learned quite a lot from this question. It doesn't always mean cancer. Hypersegmented neutrophils just means megaloblastic anemia. Megaloblastic anemia means anemia due to it's a macrocytic anemia due to impaired DNA synthesis, stuck in growth phase. Okay, these are so many. We're not gonna have enough time to look over all of them. Probably come across them in other questions. Will help us to remember also if we go and read during that time. Okay, last question, I think. For this session, a 34-year-old female presents to a family planning clinic. She is interested in having a nexplanon. Nexplanon is an evolved version of implanon, which is a progesterone implant we put under the arm. Nexplanon inserted. What is the main adverse effect she should be counseled about? Let's see, what are the side effects of progesterone? Increased risk of cervical cancer. Not sure about that. Cervical cancer is mostly associated with human papilloma virus. The certain strains of it, especially 16, 18, 30 something. I can't remember exactly. Probably not affected by progesterone. Increased risk of venous thromboembolism. That's probably the effect of estrogen. Not sure if that's caused by progesterone. Irregular menstrual bleeding, definitely. Progesterone. Increased risk of stroke. That's a side effect of estrogen again. Increased risk of endometrial cancer. Progesterone actually protects. It's progesterone protects your endometrium. So let's look. Yes, the answer is irregular menstrual bleeding. Implantable contraceptives. Okay, we can go through this. Implantable contraceptives. Implanon was the original non-biodegradable subdermal contraceptive implant, which has been replaced by nexplanon, the next generation of implanon, nexplanon. From a pharmacological perspective, nexplanon is the same as implanon. The two main differences are the applicator has been redesigned to try and prevent deep insertions. In other words, subcutaneous or intramuscular. So it's supposed to be subdermal, but sometimes when you insert it, it becomes subcutaneous or intramuscular, which is not supposed to be. So they changed the device where you implant it, so it's always subdermal. It is radio opaque and therefore easier to locate if implantable. Impalpable, I mean. Both versions slowly releases the progestogen hormone, etonogestrel. They are typically inserted in the proximal non-dominant arm, just overlying the tricep. The main mechanism of action is preventing ovulation. They also work by thickening the cervical mucus. Key points: highly effective, failure rate of 0.07 per 100 women years. It is the most effective form of contraception. Long acting, lasts 3 years. Doesn't, oh wow, that's a long time. Doesn't contain estrogen, so can be used if past history of thromboembolism, migraine, etc. Can be inserted immediately following termination of pregnancy. Disadvantages include the need for a trained professional to insert and remove device. Additional contraceptive methods are needed for the first 7 days, if not inserted on day 1 to 5 of a woman's menstrual cycle. Adverse effects: irregular or heavy bleeding is a main problem. This is sometimes managed using a co-prescription of a combined oral contraceptive pill. It should be remembered that to do a speculum exam or sexually transmitted infection check if the bleeding continues. Yeah, because it might mask something more sinister. So if bleeding continues, you gotta check. Progesterone effects: headache, nausea, and breast pain. So these are the progesterone effects: headache, nausea, breast pain. Okay. Interactions: enzyme-inducing drugs such as certain anti-epileptic and rifampicin may reduce the efficacy of nexplanon. Yeah, because progesterone is affected, is broken down by CYP450 enzymes, and these things, anti-epileptics, most of them are inducers. And rifampicin is an anti-TB drug, which is also a CYP450 inducer. So it break down the progesterone, probably make it subtherapeutic in those cases. The FSRH, what does FSRH stand for? FSRH, Faculty of Sexual and Reproductive Health, advises that women should be advised to switch to a method unaffected by enzyme-inducing drugs or to use additional contraception until 28 days after stopping the treatment. Contraindications: UK-MEC3, ischemic heart disease, or stroke for continuation. If initiation, then UK-MEC2. Unexplained suspicious vaginal bleeding, past breast cancer, severe liver cirrhosis, liver cancer, UK-MEC4, current breast cancer. So UK-MEC3 means proven risks generally outweigh the advantages, and UK-MEC4 means a condition which represents an unacceptable risk if the contraceptive method is used. Reason being, if you have breast cancer, it might be estrogen, they are ER positive, PR positive, HER2 positive. So if it's progesterone receptor positive, giving progesterone will induce the growth of the tumor. So there's absolute contraindication if you have breast cancer, although you don't know whether it's progesterone receptor positive or not. Ischemic heart disease and stroke, I'm not so sure why. Side effects include headaches, so it might be related. Suspicious vaginal bleeding, you don't want to mask the bleeding with something else, because you put them on the implant. People are gonna think their bleeding is normal because of the implant. If they got bleeding, you want to investigate it first. Past breast cancer, okay, increases your risk of having breast cancer, but it's not absolute contraindication. Severe liver cirrhosis, because your liver produces your CYP450 enzymes. If you have liver cirrhosis, your liver is not producing any enzymes. Same goes with liver cancer. Liver function is impaired. So if you're not producing enzymes, you can't break down the progesterone and you might have an overdose instead. Yep. And that's what we learned. Hope it was helpful for you going through these questions with me. That's all for now. Let's stop this recording.